Hi, everybody, and welcome to Dentistry Unmasked. I'm Pam Maragliano Muniz, and with me, as always, David Rice. David, how are you?
Pam, I am great. Super psyched for today. We might know a guy who knows a thing or two that most dentists don't know. I don't know.
I think we know a guy. So, welcome, Dr. Brian Novy. I'm so thrilled to have you here with us.
Thank you. I'm a guy. I'm that guy. Am
You're
I
Yeah.
that
that
guy?
guy.
Or do you have another guest?
No, this
No.
is it.
Wow.
We need a guy. It's fun to say that I got a guy.
I got a
Yeah.
guy.
Bob
So,
Sacamano's father, right?
so here's the thing. We've known each other for a long time. We've been friends for a long time. I always say that you're one of like a very, very elite few that have been to both my weddings. And it's interesting because we became friends before I actually heard you lecture. And one of my favorite intros I've ever witnessed as an attendee for CE was yours. And I remember as you were being introduced, like normally it's very common. It's like CE and you're listening to a bio and you're like kind of take a nap for 30 seconds and then the lecture starts. Your lecture started differently. And it was, ever hear 4 out of 5 dentists agree? And did you ever wonder who's that one guy? Like, who's the guy that doesn't agree with the 4 out of the 5 dentists? And that's you. You're that guy on a number of topics, more than I even realized. So let's talk about some things that are accepted in dentistry, but really have no foundation really behind them.
Like accepted but unacceptable.
Yes.
Like uncomfortable that we're comfortable with.
Yes.
Yes.
Okay. You're scaring me because you said this is unscripted, and even though we spent a dinner together planning for this, we never did discuss what we were going to talk about because I lost my phone. So then that whole evening, wow. Okay. So for the audience, just so you know, this is completely unscripted. I don't really know what they're going to ask me. I thought we were going to talk about Pontics.
We could.
We
And I was
could
going to
talk
ask you,
about
Dr.
politics.
Margoliano Moniz, what is the best Pontic material of choice? But we're not so okay. And I've been pointing out I'm not the fifth dentist. The fifth dentist is someone else. I'm the at all dentist. I'm one of the at alls.
That's fair.
That is fair.
All
All right,
at all.
so let's start here. Like
Okay.
one thing that kind of is so strange to me is that, for example, biofilm research dates back to the 70s, right? And we
1870s?
know, well, I think 1970s, but it could
Oh,
be
okay.
it could be longer than that. But
Biofilm. True biofilm
like
research.
dental
When
biofilm,
we think
that kind
about
of thing.
biofilm. Okay.
Yes.
Biofilm dynamics. Okay.
Like I'm taking us back like Jan Lindy 1979 kind of story where
Okay.
we know that biofilm will mature and cause significant inflammation in about 3 months. And this is something that's been stated in literature for decades now. Yet this one toothpaste commercial in the 50s said, go see your dentist twice a year. And we've made this 6-month prophy like gospel, like it's like accepted among people, dentists, hygienists, like across the board when we're not even getting people healthier every 6 months. So I want to hear some things from you. So, for example, you've been kind of labeled maybe as somebody who doesn't get that excited about fluoride. Let's talk about why that might be the case.
Whoa. Well, I was going along with you there. I was in lockstep with you. I felt like we were in a state of flow there. And I was thinking, this is going to be easy. We're just going to talk about biofilm and how we went so wrong about 50 years ago and started chasing the wrong thing. And I'm thinking in my head about the latest research I just read about the biofilm actually grows into this animal that like crawls over the teeth. That's what was described that's what we were talking about at the Canadian Academy of Pediatric Dentistry a while back. And then out of left field there, Dr. Margoliano Muniz and Dr. David Rice, I'm going to hold you responsible for where she went with that. Then she said, oh, but you have a reputation for being, and she didn't say anti-fluoride. She said it in a very nice way. And I'm so upset right now. I don't even remember what the question was. You just came out of left field with a sucker punch there. I'm not anti-fluoride. How can I be anti-fluoride? I'm pro-glass ionomer. You can't be pro-glass ionomer and anti-fluoride. But okay, so there I've defended myself. Now, what was your question?
Why?
Why am I anti-fluoride? I'm not.
No, you're not anti-fluoride, but you've been known to not rely on fluoride the same way as, say, the dental community.
Okay, so here's you want to know why? You want to know why? Page 1 of the Journal of Dental Research in 2015. Page 1 of the Journal of Dental Research in 2015. And ask yourself, does the editor of the Journal of Dental Research put thought into what paper is going to go on page 1? I mean, like, ask yourself. So you open up the first journal of the year in 2015. What do you find on page 1? Have I made the point clear? It's on page 1. In the abstract on page 1, it says, and I quote, "In the presence of biofilm, sodium fluoride application resulted in net demineralization. In contrast, nanohydroxyapatite induced remineralization, and the presence of biofilm enhanced the effect." So that was the statement for me that really started, because I remember writing a paper back in dental school with Evan and Doug. We wrote a paper on occult caries, my first year in dental school. And we had to write it. It was the first group project in dental school. And we wrote a paper on occult caries. And the last mention of occult caries, I remember when we did that literature review, was in 1995, where they talked about what happens when you misuse fluoride. And I remember being taught the harebrained idea that plaque can be a reservoir for fluoride. You want to get me worked up into a lather, start spewing that bull honky that plaque can be a reservoir for fluoride. I understand that plaque can be a reservoir for a low level of fluoride, and it can shift this Demon-Riemann balance if you have a very low dose of fluoride in the plaque and then the pH is just right. Sure, you want the pH to be slightly acidic, so you're creating fluorapatite and you're removing calcium from the tooth surface, or excuse me, the hydroxyl groups from the hydroxyapatite crystal, replace it with the fluoride ion. And I'm sorry, Dr. Rice, for getting a little too inorganic chemistry, because I see your eyes glazing over there. But you do need that sort of Riemann-Demon balance and the Henderson-Hasselbalch equation going back and forth on the tooth surface, right, to create that fluorapatite. But many of us, no, I'm not going to say us because I'm not guilty of this anymore, but there are many clinicians out there who, I'm going to say, allow their teams to willy-nilly do a very quick prophy and just, get the teeth cursory clean and then coat the teeth in a high concentration fluoride varnish. And when you combine fluoride varnish with plaque, you have to ask yourself, if that plaque is acidic, we were all taught in dental school, acidic plaque takes fluoride, turns it into HF, transports it across the cell membrane of the bacteria in the biofilm. Those two ions disassociate from each other. The fluoride interrupts the enolase enzyme in the glycolytic pathway, so it shuts down glycolysis in the bacteria. And now you have this little extra proton hanging out in the cytoplasm of the bacteria, and that acidifies the inside of the cell. So now you've ruined the isoelectric point for all of the metabolic pathways inside of that bacteria. And you kill, or if you don't kill it, you make this thing fail to thrive. So in dental school, we're taught fluoride crosses cell membranes as HF. But no one in class ever stopped to go, wait a second, isn't HF hydrofluoric acid? In what universe do I want to put hydrofluoric acid on a tooth? And yet we understand from a microbiological standpoint, that's what happens when you give bacteria fluoride, especially if they're acidic acidogenic bacteria. It turns that fluoride into hydrofluoric acid, which is exactly what it has to do in order for it to cross the cell membrane. But no one ever stops to say, well, then what happens when that bacteria is dead? What happens? Those protons and the fluoride don't ever get together again? Well, in 1995, we knew this was happening. It was published in the literature. This is what happens when you put the high dose fluoride on teeth that aren't clean. You get this phenomenon called occult caries or hidden caries or fluoride caries. And every clinician has seen it. It's where you cut into a tooth thinking you're going to do a sealant. You drop into this groove, and now all of a sudden you're doing a pulpotomy or worse, a pulpectomy. Wait, are those worse than one of worse than the other, right? I don't know. I'm not a dentist. So, or you're going, what the hell? I thought I was, excuse me, can I say that here?
Yeah,
sure. Thinking, what the heck? What the heck? I thought we were going to do a sealant here. I thought I came in here just do a little fissurotomy, and now I'm thinking, oh my gosh, is this kid? Do we need to do a stainless steel crown? That's occult caries. That's what happens when you don't get the grooves clean, and someone who's not thinking and who's trying to go way too fast in practice because they're being driven by, I'm going to say, a wrong incentive model. And Pam, you know how I feel about this because we talked about this in the car the other night. And by the way, I changed that in the paper. You're welcome. Thank you very much for that feedback. We as doctors in the practice, as leaders of the healthcare team, push the incentive to get the more procedures done instead of asking ourselves, is the patient getting healthier because of what I'm doing? Did I get the teeth clean and then provide a true preventive service, which is the prophylaxis, which is the preventing of disease? And I would say we should really get rid of the term preventing disease, and instead let's just make patients healthier, do something to make them healthier, which is why I'm so against Carrie's risk assessment. But maybe we're getting already off topic with the. Did I answer your question about fluoride? I'm not anti-fluoride. I'm anti the misuse of high dose of fluoride. And I'm going to quote JADA. There's a paper by Garcia and Godoy on the on fluoride concentration in the mouth. And if you look at what it says in JADA, JADA says only a minute fluoride concentration is needed to initiate and maintain the remineralization process. And what is a minute concentration? It's not 1 part per million. It's 0.03 to 0.08 parts per million. Now, I talked to a fluoride guru chemist guy who really understands fluoride dynamics. And let me just be clear, I am not that guy, okay? I'm not that guy. But he explained to me, and I had never heard this before, and Pam, this is why I was late. This is why you were late getting home the other night, was because this guy was talking my ear off about fluoride. I'm like, you got to shut up with the fluoride numbers. I can't. But he was saying that actually the dose of fluoride that is actually put in the mouth, by the time it interacts with saliva and biofilm and all the other stuff, all the other biochemical and inorganic chemistry that's going on in the mouth, you're actually only getting 1/10 the dose. Now, I've never heard that before, but I find that very intriguing, because that kind of makes sense when you talk about 1 part per million in water works so well, and yet it trickles down into the scientific standpoint, 0.03 to 0.08 parts per million, which is about 1/10, right? So I think it's pretty interesting, that thought, but I've never heard that before, and I have to go look at that. But which makes me question, well, what's happening to the other 22,000 parts per million that are in that fluoride varnish that we're using? And so what I take away from that page 1 of the Journal of Dental Research 2015 is that, and what everyone should take away, and what the authors want you to take away from that paper, is we really need to second guess the fluoride dynamics that we have been not brainwashed to believe, but the fluoride dynamics that we've been taught simply because we're trying to back ourselves up and defend the safe use of this anion, right? Which I think we should have chased a different ion instead of fluoride, but we didn't. Well, the military did, but the general public did not. We can talk about that if you want. I don't know if you want to talk about that. But the idea of that 2015 paper in the Journal of Dental Research is that the problem is when you just apply sodium fluoride to the tooth and in the presence of biofilm. There isn't a problem when you apply fluoride, calcium, and phosphate. And this is what really irks me about karyology. We, and when I say we, I mean the oral healthcare community at the very highest levels of science, and I'm going to put the ADA there. We want to argue and say, in the day and age of evidence-based clinical practice, there's no evidence that calcium and phosphate have anything to do with tooth decay. Well, bull crap. Come on, seriously. We all know that the tooth is losing calcium and phosphate, but then you have no randomized controlled trial that shows it. But people like me and Pam and Dr. Rice, I don't know where you fall on the spectrum of what preventive agents you use in your practice, if you believe in calcium phosphate technology. But I have documented cases in the peer-reviewed literature, thank you to Rella Christensen for challenging me to do it, documented cases showing when you remineralize teeth with calcium and phosphate, it works. I've got a 6-year-old who's now a 16-year-old who's been healthy ever since. And he got a lot of calcium phosphate chemistry. Some would say he got a little too much fluoride because he's got fluorosis on his teeth, but it's not bad looking fluorosis. I think it's spectacular looking fluorosis. And many people say, well, I don't want any fluorosis at all. And I'm thinking, really? You don't want any fluoride at all? I would love, myself, I would love to have a little bit of fluorosis. I would. I'm sorry. Did I get off on a tangent there? I went.
No.
You got me down a rabbit hole.
I like rabbit holes. I like a few things there because and this ties to conversations we've had in the past about social media. And I think the thing that I've seen in dentistry over the last, especially 5 to 7 years, is we dumb things down way too much. And there's a whole like army of humans out there who like to beat up dental school, beat up literature, talk about we don't need to learn the Krebs cycle as a joke, which is pathetic because, you know, all I remember from this conversation is lathering. I was terrible in inorganic chemistry, but somehow got through. But Henderson-Hasselbalch actually has merit.
Yeah.
And turns out like if we're going to deliver great care, then we can't look at convenience over literature-driven care. We have to have it.
I love what I really like that. I mean, we talked about this at dinner the other night when we were supposed to be figuring out what we're going to talk about here. And clearly you were taking notes and I wasn't, because for those of you who don't know, I lost my cell phone on the way to that dinner, realized it at dinner. So my head went somewhere completely different when these two wanted to talk about, what are we going to talk about on the podcast? I'm like, forget about the darn podcast. Where's the phone?
It's all about the phone. But JDR 2015, page 1, you got that.
I did.
It doesn't work that way. I wish I could remember dates like that.
But no, I love what you're saying. I think we hide behind evidence-based clinical decision-making right now. We hide behind and say, well, the systematic reviews don't tell me to do that. Well, you know what? You got two other pillars of the evidence-based triad: the clinician's experience and the patient's needs and wants. And I can't think of any patient that doesn't want their dentist to try harder to not drill their tooth. And to say, oh, if there's something you can do that doesn't involve a drill, that I can reverse this cavity using chemistry, I think I would like to try that. What patient says, no, I don't want to do that. I really want you to give me the shot. Well, actually, I can think of one patient who would say that. I go, no, I want the shot.
Just that one.
There's only one. There's only one.
There's always got to be one.
They're a fun patient, though, aren't they? But kind of.
Yeah, they like us. They keep coming back for the torture, which we secretly somehow like. I don't know.
Well, that leads me to a Seinfeld joke, which we can't get into brands like Seinfeld.
Context, Pam.
Pam, get us back on track here.
So, okay. I think you've given us a lot to think about. And
done.
What do we do? Do we do a better job removing biofilm before placing a fluoride varnish application, or do we consider different products? And, as far as, or different materials or different chemistries to help to keep get our patients healthy and then keep them healthy.
I think you can go either direction. And I think we make karyology too difficult. And granted, I'm guilty of this myself, because early on during the CAMBRA movement, I think people wanted to be able to hang their hats on like a CAMBRA protocol. And I think it's funny, as I travel around, people go, I'm using the CAMBRA form. I'm following the CAMBRA protocol. I'm like, there is no CAMBRA form. There is no CAMBRA protocol. I mean, there are things that are close that people say that, but CAMBRA's never come out and says, this is our protocol. This is our caries risk assessment form. And I know the folks at CAMBRA well, and they don't force a form. They don't force a protocol. It's all about identifying why the patient is getting the disease. And we all know how to do that, but we seem to think that you need a form to do it. And I don't want anyone to use a form when you do a caries risk assessment, except in school, to learn what you need to go find, but get rid of that form as fast as you possibly can. And make it all about identifying what are the risk factors that you can actually modify. And Pam, to your point, two very easily I think the easiest things to modify are, can we clean the teeth better? And so we have CDT codes for, I taught the patient how to brush their teeth better, although many of us would say giving the patient a toothbrush is the same thing as oral hygiene instruction. And Pam, we've talked about this. I hate prophies. I've always hated prophies. I remember disclosing a patient's teeth and using a prophy cup and trying to clean everything off, thinking, well, this will be great. I'll know when I'm done. Only to find out there are dimples in the tooth surface that nothing comes out of. You got margins of restorations, which you just scrubbed that stuff and smashed it down into those margins, which are open anyway. And you didn't get underneath the gum line. And if you didn't get underneath the gums, you abraded the gingiva on top. So the attached gingiva is now abraded. And people are thinking, well, then you're not doing a careful job. I'm like, well, who really does a careful polish? I don't know of anyone who really does a careful, meticulous polish. So I started brushing my patient's teeth with a special gel which breaks down the biofilm to get their teeth really clean in the office. So they feel that difference from me brushing their teeth. And they also know that's the way I want it to feel when you're at home. Even if it doesn't feel like that all the time, but if you get that feeling of, because my patients say, my gosh, it feels like that brush is spinning, but I don't see you actually spinning in your fingers. How are you doing that? Well, that's the way a small circle is supposed to feel if you do it correctly. And it's okay if you're not. I didn't realize what a small circle is supposed to feel. I guarantee you neither one of you did either until you were assaulted into properly how to brush your teeth with, I don't know, Dr. Rice, were you taught the modified Bass technique? You were probably taught the Robbins technique back when you were in school. I mean, that was.
No, modified Bass, like circa 1990s, early 90s.
Okay, so we all come from the same place then.
Yeah.
But I mean, I don't believe in the modified Bass technique. It's just not right. I myself prefer a 48-degree angle. It's not 45. It needs to be deeper than that. But we harp on these details and say, no, you have to use the modified Bass technique. Do you? How about you just clean your teeth a little bit better, a little bit more meticulously? I ask my patients, if you can just give me 8 minutes at night in the bathroom before you go to bed. You don't have to brush your teeth any other time of day, and I can keep you healthy. Now, I don't really think I want 8 minutes at night, and I don't think it's realistic, but I make my patient think that right from the get-go that, well, 8 minutes a night, I don't think I can do that. Okay, well, then you're already set up for failure. So can you give me 4 minutes a night? Can you give me brushing 2 minutes and then flossing and then a really quick brush one more time? Maybe you can't do that. But so Pam, to your point, your question was, so what do we do? Get the teeth cleaner? Yeah, you could. So patients spend more time brushing their teeth. I don't think they're going to do that. Until they convert, right? There's that moment that patients convert from the oral health enemy to the oral health ally, where they start going, actually, I can't not floss anymore. Like now you've got me to a point where I just think about the stuff that's growing on my teeth when I go to bed, and I have to go into the bathroom and remove it. And we've had those patients, and those are the fun ones, right? We're like, oh my gosh, like, I wonder what it was that made this patient like flip all of a sudden. And it's, I think when they get out of pain, and too often, I talked about this when we were all in Quebec together in my lectures. We harp on patients who have gingivitis and periodontal disease about, you better start brushing better and get in there, get all these little nooks and crannies. What patient, after they've just had scaling and root planing, is going to go in there and brush aggressively? They're not. And I think we need, and I don't care how soft that toothbrush is, if you're not giving that patient an ultra soft toothbrush, like a velvet toothbrush, or an ultra suave post-surgery, surgical brush or something. If you're not giving that brush to the patient to turn them on to toothbrushing so they don't have pain and tenderness when they brush, what hope do we have for them to actually continue the brushing habit and develop these really good home techniques that keep them healthy? So I think we can, and to your, again, answering your question, Pam, you could, if patients aren't going to clean their teeth really, really well and be meticulous, well, then we have therapeutics that we can give them that, well, if you're not going to get everything off your teeth, at least put this in there so that the biofilm that is left has things like some excess protein and excess calcium and excess phosphate, so that it buffers that plaque acid, which is inevitably going to be created. So you either get the teeth squeaky clean, which is difficult to do. Although I will say that there are some really cool tricks. I mean, have your patient suck on clove candy or cinnamon candy, and you will keep their mouth a heck of a lot cleaner, because those two candies with cinnamon oil and with clove oil in them, and I would imagine even cardamom candy, they have natural antibacterial compounds in there. And you notice that patients develop less biofilm when they consume that candy, when they suck on that hard candy. So I think we have to be very nimble, very flexible with our patients to say, I've got lots of ways to get you over this initial hurdle of we need to get you healthier, but it's going to take, we got to get over this hump of dis-ease to get into a state of homeostasis. And in order to get over that hump, maybe the patient is going to leave your office and start brushing 10 minutes for the next month until they really develop good brushing habits. Probably not. But after coming back for a couple of restorative appointments and having them feel how I brush their teeth, and talking to them about, so, what did you try? What did you switch up from last time? And just building on those small little successes instead of trying to change everything all at once. Because my gosh, if there's anything I've learned, the patients who fall flat on their face, it's when we try to overdo it. The patients who succeed are the ones where I start with, can you just brush right here? Just brush right here. Like, no, but can I have a special toothpaste? No, you're not ready for a special toothpaste. Just show me you can brush right here first. And then celebrate that success that, wow, it looks like you're really doing a good job brushing. Would you mind trying a different toothpaste? Or can you try leaving the toothpaste foam in your mouth a little bit longer and spitting all the excess out, but leaving some residue in there? And then start magnifying those little tiny changes instead of giving the patient an electric toothbrush, which I think is great. But I think you got to get the patient to that place of brushing their teeth really well first, because I've seen patients who they get gung ho, like, well, wouldn't a power toothbrush be better? Yes, it would. I have no doubt it would be better, but not right now for you. And I find that when you withhold it from the patient, you say, not right now, they want to try harder to get that thing that you're withholding from them. You're dangling a carrot, and my carrot is an electric toothbrush. And many of us are like, no, I want to give it to them now. They can benefit. No, they can't benefit from it. They don't even know how to use a regular toothbrush yet. I'm sorry. Anyways, that's what I'm thinking.
So many good things. And you know what's really kind of sad? We only have a couple of minutes left. And I was wondering if you could, in like a lightning round, talk about the magic of glass ionomer, which you mentioned earlier, and other minerals that will help to prevent caries.
The magic? Well, that doesn't sound very evidence-based when you use the M word. Evidence-based clinical decision-making is not magic.
I never called myself an evidence-based dentist. I like magic. And you know,
I do too. We were talking about how I want to incorporate it in my lectures moving forward, but it's very difficult. I don't want to screw up a magic trick in front of a big audience. Wouldn't that suck? Like, oh, it was a good lecture, but he screwed up the magic. But we're not here to talk about that. You want to have your lightning round about glass ionomer. Well, you know I love glass ionomer. I love glass ionomer. I love glass ionomer because it chemically fuses to the tooth and you have a true ion exchange. What I find is that glass ionomer itself burns people. And when I say it burns people, you and I talk about this, Pam. You struggle with, yeah, I know this is a great material that can resist recurrent decay and has a wonderful coefficient of thermal expansion, but I don't want to use a product that doesn't have an acceptable longevity in the patient's mouth. And if it's going to dissolve away, what does that say about my clinical technique if my glass ionomer is dissolving away? So I think the magic of glass ionomer comes from, as we started this, being comfortable being uncomfortable, and glass ionomer has a learning curve. You have to, when you polish this, I mean, my assistants know I'm going to scream at you if you blow air on me or if you suction while I'm contouring my glass ionomer. Even my patients know the cardinal sin of working with glass ionomer is don't dry it out. All of my patients even know that. If I say, what's the because I ask Megan each time, Megan, what's the cardinal sin of working this with sterile? Don't dry it out. I know not allowed to suction while you work. I'm like, exactly. So get the heck away from me with your suction. You can't dry it out and you have to coat them. And everyone in my lectures, Pam, you've heard me say this because I had research students who found out that you couldn't move fluoride. And Dr. Rice, you don't know this, but I had research students over like almost 15 years ago, Danny and Elijah, who taught me that we can't move fluoride through composite. So if you coat your glass ionomer in a composite coating agent, which I absolutely think you need to do, because that's what prevents the degradation, that lack of retention event that everyone freaks out about, which I don't nearly see with the same frequency other clinicians do because they don't coat their restorations the way I do. So if you coat them, you don't see that lack of retention event. And Pam, you've seen you've seen my highest risk patients who I then referred to you because she lost her dental benefits in my office. So I sent her to see you. And I will admit, I sent her to you because I was like, oh, the only person who can help her is Pam. And you saw my work and I'm sure you're like, Brian, what were you thinking? I'm like, I know it's glass ionomer in there, Pam. But if you take an Explore and you poke into that, it's hard and it's firm. And Pam, Dave, you don't know this. Excuse me, Dr. Rice. You don't know this, but Pam called me and said, you better come here to this office and you better register this practice location with the state of Massachusetts because you better keep taking care of her. I don't want to inherit this. Your glass ionomer is having lack of retention events. Like, well, yes, the woman is on like 28 medication or xerostomia inducing medication. She's got lupus. And I mean, she's got her health history is like an encyclopedia. The poor woman is just her poor mouth. And Pam, we've talked about it. She is one of those patients who, no, we are going to lose everything, but we're going to lose it slowly. And Pam and I have talked. You're not going to save every patient. And it took me a little while to get to that get to that place. But patients are willing to try a heck of a lot harder than we think they are. And too often we don't give them benefit of the doubt, and we don't talk to them in a way that changes their behavior, because you don't change anyone's behavior by telling them to go home and do something. That's the take-home message for my lectures these days. Is it's not about the therapeutics. It's about how we talk to our patients. And ironically, if you tell a patient not to do something, that's the way they go, and that's when they go and do it. It's mind-boggling. And we keep saying, no, that can't be right. I need to practice the ethical tenet of veracity in the practice and always tell the patient the truth. Well, the truth is, I want you to not go do this, because psychologically I know then you're going to go do it.
Well, then that brings me to 2 final points.
Did we go over on time?
The dental community does not want you on Instagram. I put a post after our trip on a Reels from our road trip up to Montreal, and everybody wants you there. So I'm going to tell you not to join Instagram.
Oh, I was like, are you serious? Why would you say that to me live on a podcast?
It totally works.
You know, I just went in my head. You just told me nobody wants me.
You're like, so I'm going to get my ass on Instagram because we want you there.
I don't want. Last thing I need is to be on social media, Pam. I'm working on my paper. You know my paper.
I know the paper. I know.
I read it to you. I read it to you the whole way home from Montreal.
I know. I heard the whole thing. It's so
Were you
good.
driving, Pam?
I was.
Okay, then it had to be good, or you guys would have been in a ditch.
No, not a ditch, not even close. It was an amazing paper, but
22 pages on early childhood caries.
I'm just saying your friends miss you on social media, so it'd be delightful if you would join us on Instagram, number 1. Number 2, the question everybody really wants to know. They literally sat here with us for this entire time. Did you get your phone back?
I did get my phone back through a very weird circuit. You were there, Pam. You were there, and you're setting me up.
I'm just helping the people. They want to know. I can tell. They're
Dr.
like,
Rice, did you hear the story of what happened? So how we got my phone back? Because I activated Find My iPhone, but because my phone was in airplane mode, which you remember, because it was in airplane mode when I text messaged my mother from the bar to say I'm safely in Montreal with Pam. It pinged when it got back into the Wi-Fi range of the hotel, and I went running down the cab line asking each cab driver if they had my phone. And sure enough, I go up to this guy, and it wasn't getting the missing text message that says, this phone has been lost. Please bring it back to the Intercontinental Hotel. Leave it with the concierge. Leave your contact information for a large Venmo reward. The guy didn't even see that. He had no idea, because it wasn't getting any messages because it was in airplane mode. But then my phone pinged me that it was outside the hotel. So Pam and I go running out onto the streets of Montreal. I'm like, it's around here somewhere. And she's like, where, Brian, your phone is gone. We need to go home. I have to practice tomorrow. I have patients tomorrow. I was like, my phone is here, Pam. My phone says it's here. So I just went down the whole line of cabs, knocking on windows. And sure enough, this guy who didn't look anything like the way I remembered him, and his cab was a different color than I remembered. But I said, do you have my phone? He goes, yeah. I was like, you have my phone? He goes, yeah. I was like, you have my phone? He goes, yeah. And he's looking around his car, rummaging through everything. And then he just hands me my phone. It's like, oh my God, it's my phone. Crazy, right? And if I hadn't been late to meet you, Pam, and I was like 2.5 hours late to meet you to go home, we would have completely missed it, because he wouldn't have been there at all with my phone. And we would have left, and he would have driven up and been sitting there, and it would have never pinged. So I'm telling you, the universe, that trip to Montreal, it was an amazing. Oh, it was brought the 3 of us together in that restaurant for me to lose my phone. Wait a second, I wouldn't have even lost my phone if it weren't for you.
True.
So
the butterfly
never mind.
effect.
Never mind. I just said it's your fault because you didn't check the backseat of the cab when we got out.
That was me. I'm sorry.
Or as Pam said, you just let us take an Uber, but no, you had to hail a cab on the streets of Montreal.
It happens. It happens.
It was
Thank
all.
This was awesome.
I got my phone. I got my phone back. Montreal is a great place. Those cab drivers are awesome.
Great city, great people, great episode. Pam, you want to take us home? Because I learned a lot. I actually made 2 pages of notes. No
Oh my gosh.
kidding.
I know. I always learn something when I hang out with you, Brian. Thank you so much. This was amazing. I appreciate your time. I know, just to anticipate the invitation back, because we're certainly going to want to have you back. So love you. Thank you. And everybody out there, we will see you next week.
Thank you, everyone, for watching or listening to the show this week. And thanks to our guests and sponsors on this episode.
Please check out our social media at Dr. Pamela_Maragliano and at Dental Economics Official.
Or you can check me out at Ignite DDS or at Dr. David Rice.
And go to dentaleconomics.com to receive dental economics. You can choose to receive DE in print or digitally, and you can also get the details of our Principles of Practice Management Conference on our website.
If you have topics or guests or anything you'd like to talk about on the show, send us an email to dentistryunmaskedpodcast@gmail.com, and we will do our very best to make it happen. Thanks again, and we'll see you next week.